here. Now you can wait for a while to make the other to join us. Okay, welcome everyone. In the beginning, I would like to thank Dr. Al-Qahtani for inviting me to share information with you regarding these topics. First of all, my name is Dr. Ayman Mandorah. I'm consultant endodontist and I'm a member of Scientific Council of Saudi Board Endodontics. Today I will talk briefly about diagnosis and interpretation of our radiograph during treatments. Let us start at the beginning by talk about the components of diagnosis. The main component of diagnosis, as you will see here, is if you think that diagnosis is about the components, you have to fit all together. We have to start by sheet complaint, dental medical history, and we'll go for clinical examination, even clinically or by radiographs, and ending by periodontal and clinical test. So all this information is very important to us to have a correct diagnosis. If you go about the component of diagnosis, we have four more components. I will try to discuss the most important issue in this live stream because time is very short. I will not talk about everything the important issues regarding these topics. We have subjective information that given by patients, and you have objectives, is what you find when you are doing examination, either by radiograph or clinically, and we have assessments by yourself by using tools that aid you to have a correct diagnosis, either by blood test or apical test. Then after that, we will conclude or collect all together and reach to our plan of treatment. What is our steps or plan for this case? Let us talk about why sometimes we find difficulty to have a correct diagnosis. We have about more 4 or 5 issues regarding these problems. Why you sometimes have difficulty? Because the pulp and periapical tissues are dynamics and progressives. Every day the apical status of the apical or pulpal stage it change from time to time. So always we have different dynamic change in the histological picture of our teeth. Second thing, always we have variation in sign and symptoms, and this is always, it depends on the state. Sometimes it has severe pain, suddenly there is no pain. Sometimes has slight pain, then severe pain, then there is no pain. So it's always changing. The third difficulty in regarding our diagnosis is we have both. We have two components. We have apical and we have pulpal. So all this will affect our decision, because we have to divide the tooth by coronal part diagnosis, what you call it pulpal, and apical part diagnosis, and you have to correlate between both of them. Other thing that make our diagnosis difficult is the examinations of radiographs sometimes give confusing results. Sometimes we are not sure if there is lesion or there is no lesion. I'm not sure. Maybe I will see. I will see, for example, radiograph. I saw there is a lesion. Maybe my friend see. He will say. No, there is no lesion. So sometimes it gives us conflicting results regarding the disease. The fourth or fifth problem regarding our difficulty in diagnosis is incorrect application of clinical tests. sometimes we know that we have bulbar test, apical test, but the problem is we don't have the enough skills to apply the test. Maybe you are doing the test in the wrong way, so we have wrong result. Finally, sometimes we don't have the skill to correlate between examination result of the patient. Sometimes we don't have the skill that there is a lesion in the graph and the bulbar test. There is no correlation between our graph and our clinical result. Anyway, anytime, don't start our treatment without accurate diagnosis. You have to make sure that all these difficulties should be solved to have a correct diagnosis. Let us start to talk about the chief complaint. Chief complaint for us as a dentist is, as all of you know, is pain. We have 7 steps or items to have a correct diagnosis. Number 1, frequency of pain. That means the pain frequency, how many times every day you have the pain. You have to think about opportunity. You have to think about duration, history, location, severity, nature. All this should be considered as very essential questions should be asked to have the correct diagnosis. Let us start by history. You have to ask when the pain start, how it's progressed, what the pain related to specific experience, if there is any recent trauma, if there is any recent filling or old filling, if there is any history regarding the tooth history. Also, we have to think about localization of the pain. If the pain is localized to one tooth or one quadrant or one side or both sides. For example, if the patient come to you and he said, I have a pain in this side. If he cannot locate the tooth, that means the pain is diffuse. And actually that means the inflammation is still in the early stage or in the tissue. When the patient he can localize that the tooth is the most painful tooth, that means we have involved with the BDL. That means the inflammation go from the pulp to the BDL. So it's very important to ask about the localization or location of the pain to see if the case has acute bulbitis, organic apical abscess, or maybe has irreversible bulbitis, or maybe will have normal bulb. So according to the location, you can decide. And also you have to ask about the severity of pain. You have to think about the severity of pain. You ask him if you, as you know, you can use what you call visual analog scale from 0 to 10. 10 means I cannot tolerate the pain. 0 that means no pain. And this is depend on the patient threshold, and is it actually not absolute indication for our treatment, but give you some hint that the pain is start with maybe 2, then become 9, then again go again to 2 or 4. So give you some hint to understand the histological status of our bulb reaction to our treatment. As you go, we can use visual analog scale. As you see here, it's from no pain, 1, 0, and 10 is very acute pain. The stimulus of pain even is very important to know exactly and ask him the pain is due to cold, due to hot, is due to look for this for options, is due to biting, showing, touching, pressure. So all this word has different descriptions. So you have to ask exactly when you feel the pain exactly. And you have to think if you feel pain when you push on the gum or without pushing your finger on the gum. And the last thing you have to ask about the duration of pain. How long does it after removing the stimulus stay? How is this minutes? Is this hours? Is this seconds? You have to ask exactly when, every time when you have pain, how long you have this pain. If you summarize all what we mentioned in the previous slide, in this table, you have to think about characteristics of the pain, type of pain, ache, tenderness, dull pain, throbbing pain, stabbing pain, and so on. You have to think about severity. Is it mild? That means it's managed by analgesic. Or moderate, is there is no response to analgesic. Or maybe severe, that means I cannot sleep at night. The duration, as what we mentioned, is it second, minutes, or hours? Think about natural, continuous, periodic. If there is continuous sometimes and stop suddenly and again he can continue as a continuous. Think about initiating factor, when the pain start and how the pain is relieved, and the localization, and if there is any referred pain to any other organ in the third ear or TMJ or sometimes wisdom tooth. So think about all this item to conclude exactly what we have or what the origin of the pain exactly. Let's shift to another steps in our or another second part in our live stream or presentation is the clinical examination. Actually, we have four main components is extra-oral, intra-oral, or comparative testing and radiographic assessment. Let us start by extra-oral. What we usually look. We have to look for 4S: swelling, scar, sinus tract, or skin color change. You have to look for all these four. What we can call it by your physical examination. It gives you a hint that we have a problem inside the mouth. When you go internal for intraoral examination, we have to look even for hard tissue or soft tissue. For soft tissue, we have to look for redness, swelling, or sinus tract. It gives you an idea we have an inflammation or localization or local inflammation in this area. When you look to hard tissue, we have to look with a different eyes. We have to look with thinking out of the box. For example, when you see a case like this, wearing passive, what this mean? This means this patient has triumphal occlusion or he has aggressive force in the tooth. That means you can think in this case maybe we'll have crack or fracture. For example, for another example, if you have a leakage like this, very small leakage, this can lead to millions of bacteria to go inside and make recurrent caries and recurrent infection and irritable dentitis. Also, we have to look for recessions or exposed dentin. It make a perio-indurulation and it can make bulb exposure or necrosis with the time. And the very important issue that maybe all of us neglect is the magnifications. Magnification is very important to look for fracture or crack. Let me ask you a question. How many of you using magnifications? Magnification actually I think is very important nowadays because we see a lot of patients with problem and you cannot see exactly the problem because we don't use the magnifications either by loops or by dental microscopes. Why we have to use the magnifications? Actually, we have many advantages of magnifications. You can find cracks, you can find fractures, even we can find missing canal. If you have a perforation there, you can find it. You can find it easily. If you wanna make education video, you can record by the microscope for educate your patient about his problem. Also, we can make a reports or claim if you have any insurance problem with the company, and also we can make a documentation if you want to make to show that we don't have a problem in this case by recording a video or a report about the case. And it's very easy to use for the treatment, especially if you have a post or gutta percha removal. For the crack, exactly especially in a case like this case, if you look here, let me show you. This case come to me with a retreatment. He did 2 times retreatments and still he has pain on biting. When I look to the radiograph, it looks okay, no problem. When I try to look why he has this pain on biting, when I make a stain, you find a vertical crack here. And because the previous dentist don't use magnification, he missed this point. And patient complain from pain every time, and without any benefit for retreatment. In this case, actually, we will go for extraction from the first time because he has crack. So please, I advise everyone to use magnification device, either by starting by loops. You can go by, for example, 2.5, then increase to 3.5, then you can reach up to 6 times maybe. And after that, you can shift to dental microscope. It's more efficient, of course, and maybe magnification reach up to 35 times than loops. Okay, now we'll go to the third objects, or the third part of our presentation is clinical test. Actually, we have thermal test. All of you, we know the cold test. Cold test is very important nowadays, and it's a reliable test to rely on. If you think when I have to use a partial or complete isolation, of course we advise to use a complete isolation in every case, especially if you are going to use an ice block, because if you don't use a complete isolation in this tooth, the melting ice will go to the neighboring tooth and make a confusing result. So all do advise to use complete isolation, and to advise all of you in every test you have to use a control tooth to see what the normal and the abnormal. For every patient we have different response, so we cannot rely on number or on a special number that if you have, for example, 3 seconds, 4 seconds, it actually is theoretical, but we have to, every patient has his control tooth, and we can see the abnormal and normal to see if the tooth is need intervention or not. Another thermal test is a heat test. Even if the patient has pain, when he drink hot water, you have to apply heat test. The same idea, you have to have an isolation, you have to try the tooth and apply the gutta percha on the buccal or labial surface of the tooth. Third test, what we call it EBT. EBT sometimes give limited information. Recently, some of the review regarding the pulpal and apical test, they claim that the cold test is more reliable than electrical pulp test, and nowadays we depend mainly on thermal or cold test most of the time. If you go to the fourth exam, what we call it the palpation test, usually you have to palpate in the front of the apices or the apex of the tooth, because we can discover from this examination that if you have apical abscess or no, if you have problem apically or no. And the most important thing in this test to put your finger in the front of the tooth, in the front of the edge of the tooth, and if you examine the our upper premolar, sometimes you have tenderness because you have some insertions of the small muscles in this area, so you have to make sure that actually you have a tenderness, not normal response, and have to compare if it with the other side of the face. For the percussion test, it's very important to think to use your finger first before applying a mirror or head mirror, because especially in the acute cases, patient cannot bite even on the tooth. If you apply a mirror, you will make the pain more aggressive than if you apply by finger. Please listen to the chief complaint exactly, and if your patient has very tenderness to percussion, please use the finger first. Don't make the pain more severe than what he has now. Some of the tools make our examination easy. It's what you call it bite test. Bite test, usually we use what you call it tooth strut. You ask patient to bite, and you have to visit. If the patient has pain when he bites, that means patient has epicarditis. If the patient has pain when he releases, that maybe he has crack or fracture. To confirm the crack or fracture, usually we have deep, narrow pocket in the tooth. That means we have a crack, and with the time, the crack line mix or form a deep pocket in this side. Because the crack pocket is usually single and isolated, but the perio pocket is usually wide and multiple. So if you have single pockets, that means maybe you will have fracture or crack. If you have multiple wide pocket, that means it will have perio problem. Let's go for the 4 parts, or the part number 4 in our presentations is X-ray or radiograph. Actually, I call it radiograph because the X-ray come to the tooth, and we have radiograph, not X-ray. X-ray we cannot see. We see the radiograph of the tooth. Actually, to understand the radiograph, you have to have 3 main important informations. You have to think about knowledge about root canal morphology, vital structures, and pathological changes. We have to look for the technique that we are doing, either type of projections, horizontal or vertical angulations. If you have to know how to trace gutta-percha and how to use digital radiograph, and finally after that you have to know how to interpret your radiographs, magnifications of course, and distinguish anatomy and pathology, and also how to observe the previous root canal filling material inside the root canal. So you have optimal radiograph techniques. We have to have well exposed and well processed radiograph, and we have to have some film holder is guide you to have an accurate or good result, like an Mandorah that we put it in the cone of the radiograph or on the cone of the X-ray, and we have optimal exposure of radiograph. Okay. Usually, or I think is mandatory, not usually, you have to have 2BA radiographs and you have to have bite wing. Why you have to have 2 periapical radiographs? Because especially in multi-rooted teeth, we cannot see all root with one radiograph. So we have 2 angulation, one straight and one with medial shift. And why you have to take bite wing? Bite wing, as all of you know, it's very important to evaluate the restorability of the tooth, because we don't want to waste our time in a tooth is not restorable. And always to think about vital structures. For example, here, if you see here, when I take a straight radiograph or straight angle radiograph, we see maybe we have a lesion here. But when we take another angulation, it actually is not a lesion, it's an incisive foramen. Even for the mental nerve down or in the lower premolar, has the same idea. You have to think about sometimes you are mistaking the mental foramen with the periapical lesion in the premolar molar areas and in the anterior area regarding incisive foramen. Even for the radiograph and episurcator, usually we have to confirm the radiograph by episurcator, because when you take a radiograph like this, we see that the file is in, but when you extract the tooth and to make sure, for example, if you are in or out, actually we are out. Even here, when you take a radiograph, we see the file is in, and when you take it out, the file is out. So usually, when you take a radiograph and you look, the file is flush with them, that means actually it's out. So you have to confirm the radiograph by episurcator, at least try to use it as much as we can in your cases. It's very important to explore this issue to avoid overfill or over preparation. Sunstruct, I think all of you know how to use tracing by using getaperches height 25 or 30 to know the origin of our lesion. It's very important to do this in cases with chronic apical abscess with Sunstruct. If you have a case come for retreatments and you see that some cedar like here or material of obturation is irregular in shape, that means maybe you will have another canal here. It gives you a guide that maybe you have another canal here. If you open the tooth again, we see you have another canal here, and if you have 2 canals. Even for upper 6 or lower molars, we see here that we have MB2. Here we have what we call it radix intermolaris or radix paramolaris. That means we have extra root. If the extra root located buccally, it's paramolaris. If it's located lingually, that means it's intermolaris. And I think the MB2 nowadays it become 60 to 85%. So now usually or most common we have MB2 than before, with aid of magnifications and with understanding the skill how to draw or drill the aqueous cavity in our molars. If you have a radiograph with obturation and you see the location of the foramen is a little bit not centralized, and actually we have deviation 1.5 to 0.8 millimeter from the straight axis or straight canal of the tooth. That means it gives us an idea where the apical foramen located, and the lesion even it be located next to the apical foramen. If you look here, that means the foramen is here. If you look here, if the foramen is even here. So not always the foramen in the center. It's almost always we have a deviation, as what we mentioned is 4 to 8.8 millimeter sometimes from the main canal. in the advanced cases, sometimes if we don't treat the crack, we have vertical root fracture, and if you have a radiograph, you see is very clear. It's what you call it a J-shaped appearance. It's very diagnostic. If you have another case, if you have another case for retreatment, and as you see here, and the gutta percha suddenly disappear, it not always means that we have ledge or we have calcification. Sometimes give you a hint that maybe we'll have another canal. So always if you have disappearance of the gutta percha, think about missing canal, like this case. And please don't sorry for the disturbance happen now. So if you want to differentiate between the internal and the external, if you want to if the disturbance of the root canal system, that means is internal. If there is no disturbance of the root canal system, that means external. So if you look to the variation of the root canal system, we have 3 root mandibular molars, we have middle mesial canal and distal canal, we have 3 rooted canal maxillary molar premolars, we have double rooted canal mandibular premolar, and we have 4 rooted canal premolar. And what I always said, always look for missing canal. What about CBCT? Is it very important to take CBCT? Actually, CBCT is very important, especially in a cases of retreatment. It gives you a very important sorry, I think we have some problem here. So the CBCT is very important to know why we need CBCT. It's very important regarding missing canal or missing very big lesion, like this case. If you take a BA, we don't have a lesion. If we take a CBCT, we have a big lesion. Dr. mentioned is very important, very informative, higher accuracy, high resolution, and you have scan time reduction. Why we need CBCT? We have to know the variation of root canal anatomy, internal resorption, external resorption, or we can think that if we have any relation to dental problem or there is no relation to dental problem. So for clinical examination of our radiograph, we have to think about preoperative and you have intraoperative. The preoperative by magnifications, history, vitality, crown abnormality, or intraoperative. Even again, you have to use magnification during examination. We have to think about orifice locations. If there is any bleeding, if there is any bubbling of thermochloride, it gives you hint that we have a perforation or problem in the axis, and we think about direction of the file and using of apex locator. And always remember, good doctor is good observer. If you have a good knowledge, if you have a good observer eyes, you will be a good doctor or good dentist in the future. Now we finish all steps regarding examination and X-ray or PA examination of our teeth or our dental cases. Let us go for our diagnosis. As you know, we have bulbal and we have apical. The bulbal we have 5 or 1, 2, 3, 4, 5, 6, 7. So what I usually is normal bulb, then bulbatus, symptomatic, asymptomatic bulbatis, that it is irreversible, or bulb necrosis previously either treated, that means had been done RCT before, or initiated, is done always by bulb extirpation. For the apical, we have normal apical tissue, then apical bulbatis either symptom or without symptom, chronic or acute apical abscess, and congenital cystitis. I will not go in detail of this because we don't have enough time. Let me show you where you have to go and read about it. In AAE, it make a recommended diagnostic terminology for all bulbal 1, 2, 3, 4, 5, 6, 7, and all apical. So we have 7 bulbal diagnosis and we have about 6 apical diagnosis. Go and read about it. It's very easy to understand and correlate between them. Here I will go directly to cases to correlate the definitions by cases. For example, this is a case number 1. I will take about 4 to 5 cases because the time is very short. For example, case number 1. This case has hypersensitive to cold and sweet. It lasts few months, then subside. That means he has very severe pain, suddenly pain subside. No response to thermal test, tenderness, biting, and pain on percussion. So every statement here have some definition or description in our mind. If the patient has sensitivity to pain and suddenly this means bulb maybe was vital and suddenly maybe become necrotic. To confirm this, when I are doing bulb test, the tooth is no response with the cold test, and when you apply finger or mirror handle, there is pain on percussion. So that means what? You can think about it. So there is no response to bulb tissue, to bulbal test. That means the bulb is necrosis. Pain on percussion or palpation. That means we have symptomatic apical periodontitis. Okay, and in this case we will go for non-surgical root canal treatment and build up and crown. And why we add congenital cystitis? Because if you look here in the radiograph, we have some radiopacity with the chronic low-grade infection or inflammation, have low-grade low or radiopacity in the distal root. Okay, so in this case we have bulb necrosis and apically symptomatic apical periodontitis with condensing osteotic. Actually, bed case need root canal treatments and build up and crown. Okay, let us to go with case number 2. Number 2 here, for example, we have mandibular right lateral incisor with apical recency. If you look here, history of trauma more than 10 years, and tooth was slightly discolored, clinically of course, not here. No response to endo eyes, adjacent teeth respond normally to bulb testing, no tender to percussion or palpation. So if you go with each statement, history of trauma, that means we have trauma. Trauma usually has bulb necrosis. Why? Because trauma make constriction of the bulb, so the blood supply reduce and usually the bulb become necrotic and the tooth become discolored. No response to endo eyes. It confirms that the bulb is necrosis or the bulb is necrotic. Adjacent tooth is normal response. That means they are vital, that the control vital, it is non-vital, and not tenderness to the percussion. That means the apically is asymptomatic apical periodontitis because there is no symptom when you are doing bulb or percussion or palpation test. So what the apical diagnosis will be yes, bulb necrosis and asymptomatic apical periodontitis. So it needs non-surgical root canal treatment, and of course bleaching because tooth is discolored. Then after that maybe crown or bleaching maybe enough, depending on the discoloration stage. Case number 3, we have mandibular first molar with large apical residency and furcation involvement, recurrent caries in distal margin of the crown, if you see here. So recurrent caries here in the margin, and no response to cold test. That means this tooth is bulbous necrotic. Drainix buccal sinus tract. If you feel gutta percha here, it gives you a tip that you have a fistula here or sinus tract. Sinus tract, and we are putting the gutta percha to make sure the origin of the sinus tract exactly from where. Then no pain on percussion and palpation. So in this case, what will be the diagnosis? Guess what? It will be bulb necrosis with chronic apical abscess. When you see a sinus tract, that means chronic apical abscess. Okay? So in this case, what you have to do, you have to remove the crown because there is a leakage. So crown removal, then we can make root canal treatment. Then we will do, of course, new crown because the old crown is leaking, so it's not used anymore. Case number 4, it's maxillary left lateral incisor with apical residency, no history of pain, and tooth is asymptomatic, no response to endo eyes or EBT, no tenderness to percussion and palpation. So no history of pain, tooth is asymptomatic, confirmed by endo eyes, that means tooth is necrotic. No tenderness to percussion, that means apically is asymptomatic. So is bulb necrosis with asymptomatic apical periodontitis. So it's non-surgical root canal treatment and of course permanent restoration. Before ending, this is I think the last case. Before ending my presentation, I will go to some questions have been asked by questionnaire that has been published last week regarding this presentation or this live stream. Let me answer them. Here is the questions I received last week. First question is, can periodontitis cause endolesion? Of course, we have perio-endolesion and we have endoperio-lesion. As much there's a communication between periodontium and the root canal system by the canal tubules or by pockets or periodontium around the tooth. So always we have a good communication between endo and perio, of course. What magnification for loops do you recommend for young dentists still learning their way around endo? Usually I recommend to start by 3.1 or 3.2 magnification factors or power. Then we can increase with time to 4.5 and ending by 6. Of course, if you have microscope, it's better. If you don't have, it's usually you have to use a loop. And I recommend to use custom loop because we have 2 loops, either customized on your eyes only for you or universal for everyone can be used. So I recommend to use custom made loops, especially for you, to have more accuracy and more benefit by using this loop. What should we don't see radiograph healing of the lesion even after re-endo? Does radiograph lesion indicate failure? Of course, you have to follow up the case. If there is a lesion